Hello, my name is Martin Cohen. I'm a psychiatrist. I live and work in Newcastle and I work with an organisation called ProCare. ProCare provides consultation and support to GPs in many areas of Australia. We provide the mental health call line whereby you, our colleagues in primary care, can contact us and seek advice. Today I'm talking on a subject which is a difficult subject to actually encompass all of the complexity in relation to. It's the subject of suicide and suicidal persons and how you assess them. So I'll first start off by defining what suicide is, talking a little bit about risk factors, and then I'll move on to a case vignette, which I think is the most practical way to think about how you assess a person who you feel may be at risk of attempting or completing suicide. So we know that the World Health Organization defines suicide as an act that is deliberately initiated. It's a willful act performed by a person with the full knowledge or expectation that they'll be ending their life. That is, that there'll be a fatal outcome. Unfortunately, completed suicide rates are increasing, and this is of great concern to federal and state governments and to all clinicians who care for and work for people who have mental health problems. But we also need to understand that there is a much broader context, which is that sitting underneath suicide and attempted suicide is another risk factor for suicide, which is deliberate self-harm. And that is a deliberate act to damage the body without suicidal intent, which is a risk factor for suicide. And indeed, this is a challenge for many clinicians in terms of understanding how to differentiate between suicide risk and acts of deliberate self-harm. So I thought I'd just start there. When I'm talking to a patient about deliberate self-harm, these are often patients, if they're young or if they're old, who have experienced some form of trauma or experiencing some form of dysphoria. The act of deliberate self-harm is never seen as lethal, can be seen as a cry for help, but oftentimes is described by people who deliberately self-harm as a way of feeling, a way of experiencing pain, a way of overcoming their lack of emotion, lack of connection to both their own emotional context, but also the world around them. If we think a little bit about trauma and a trauma load, people who've been exposed to various forms of trauma developmentally encode those traumatic environments into their experience and their memory context. When this occurs, people feel rapidly shifting, unstable mood. They feel dysphoric. They feel as though they are unable to align their emotional experience with other people. They feel very different from other people. And that's a core thing about deliberate self-harm, is that a person's experience of how they should be able to tolerate stressful life events and what they see other people being able to manage is very distressing for them. So I see deliberate self-harm as something to work with, to understand a person's context, and to help a person develop other techniques, perhaps self-soothing techniques or grounding techniques or using CBT techniques to help them manage that dysphoria, whilst we engage them in a trauma-informed therapy or assess them for an underlying mental illness such as anxiety or depression. So that's all I'm going to talk about in relation to deliberate self-harm, and moving on to thinking more about suicide. It accounts for just over 1.5% of all deaths, with 3/4 of all deaths occurring in males. We know that there are about 40 deaths per week in Australia from suicide, which is a tragedy that we all grapple with, because suicide is an outcome rather than a disease we can treat. So that's why we need to think more about suicidal ideation as something that we can work with, and the person's psychosocial environment, protective factors and risk factors is something that we actively have to work with. There are approximately 2,000 episodes of deliberate self-harm in Australia each week. So that's a sizable problem, which is why I began this talk touching on deliberate self-harm. And you'll see thematically it recurs throughout our assessment process. If we're thinking about the combination of deliberate self-harm and completed suicides in Australia, the combined rates of homicide as well as the motor vehicle toll does not equal the number of people that we've lost in Australia each week. So it's a national problem. It's an individual problem. It's an issue of social context. It's an issue of mental illness. It's an issue of education and training, which is why, quite frankly, I grappled with how I would present this talk, because the process of suicide assessment, I think I could cover in 10, 15 minutes. but to actually understand the importance of connecting with the person who's experiencing suicidal ideation, using empathy to understand their context, and not just focusing on suicidal ideation, but actually looking at risk factors, their current context, mental ill health, mental illness, other risk factors which might be impulsivity associated with ADHD, or perhaps a previous history of deliberate self-harm or previous suicide attempts is important. Just remember that suicide is the commonest cause of death in the age groups of 15 to 24. Facts about suicide are that GPs are the last health professions that are usually seen by people who are suicidal. So first of all, that in itself poses a serious question for, I guess, the structure of your clinical process. What screening instruments might be helpful for you. And in addition, when people do complete suicide or attempt suicide, how that impacts on you as primary care providers. Certainly, as a psychiatrist working with people who would be considered to be at high risk, I can tell you that some days I go home and I'm thinking through whether the safety plan I put in place for somebody with best intention and best effort is sufficient. And balancing the ethical issue of allowing a person to maintain their autonomy and not schedule them into hospital, and balancing that with my concern that the relative who promises that they'll spend 24/7 with that person and engaging the ACT team or the community mental health team in follow-up, whether those processes have all fallen into place to ensure that at this point in time that person is safe, that is, their suicidal ideation does not progress to intent, planning and completion. I can't imagine how challenging it is for you in primary care where you're seeing a large volume of people, and we know statistically that oftentimes people who complete suicide are people who statistically would be considered to be low risk. So that's a challenge for us all. That's where peer networks, peer support, education and training such as this come in handy. But at the same time, fundamentally, and I want to say this up front, you guys do a very challenging job finding a hidden agenda when somebody's presenting with multiple health complaints, then working through those health complaints, and then at the end of the session finding out that a person's marriage has broken down, they're using alcohol and they're experiencing suicidal ideation, puts inordinate stress on primary healthcare providers. And I wanted to acknowledge that. It's not lost on our profession as psychiatrists and psychologists, and just to thank you for the work that you do, because it is critical to the interface between emotional distress, mental ill health, mental illness, and risk. We know that males complete suicide more often than females. The methods that males use are usually more lethal, for example, hanging and firearms, whereas twice as many females attempt suicide but do not complete, for example, drug overdose. We know that 15 to 24 age group is the at-risk age group and it's the most common cause of death, and that motor vehicle accidents sit behind that at about 16% of all deaths in that age group, whereas completed suicides are approximately 27%. I like to think about the trajectory towards completed suicide using Reason's model, which is a Swiss cheese model, which we often use in management when we're analysing risk and looking at where we could have intervened or where we see holes within the Swiss cheese lining up to create risk. And when you have enough holes lining up, unfortunately, we lose some people. So if you think about the suicidal person, the first port of call is really their opportunity to be screened and assessed for suicide risk and creating a risk formulation. For example, I saw a 27-year-old male who presents with a recent separation from his wife in the context of significant financial adversity. He has no previous suicide attempts but presented with superficial cuts to his risk. He feels more socially isolated, and as his main social connections were through his wife. Of concern is the fact that he's currently using more alcohol than he previously has, is experiencing suicidal ideation without intent, timing, planning or wrapping up his affairs, nor is he actually rehearsing the suicide. He is accessing help, however, which is a positive thing, and he's come to your surgery. When I explore his suicidal ideation, it's based on the thought that he can see no clear future for himself. He finds himself in financial difficulties, and he feels at the very core of himself, when he reflects on the fact that he's worked hard all of his life, he really has no financial means to support his children and cannot see an obvious way out of this impossible situation. Building a safety plan together with this person is challenging because his psychosocial circumstances are bereft of support. And the ethical consideration is, well, is there immediate risk? And at the moment there isn't. Would he accept support and help by way of engaging with a psychologist and following up with yourself and perhaps a psychiatrist? Does he see suicide as the only way out? Does he have the capacity for distress release or distress tolerance? Is he responding to basic CBT techniques like deep breathing relaxation, sequential muscle relaxation, and grounding techniques? And can you engage him in the notion that suicidal ideation is a symptom of depressed mood rather than a thought or activity to act upon? Are you concerned that the self-harm is a clear indicator of increased suicide risk in the short term? I think it is. But it's worthwhile understanding whether the self-harm occurred in the context of intoxication or perceived abandonment by his friends who have not contacted him but are aligning with his now separated wife. All of these factors are complex, and to create a formulation that allows you to make a best estimate in terms of a risk formulation is all we can do. Fundamentally, it comes down to a connection with another human being, and that you can reflect back to them that you understand the stress and distress they're experiencing. And using some standardized assessment protocols, which we will provide as part of this package of information, perhaps as screening instruments for people who might present with psychological distress in your practice, you might have an inkling early on and be able to devote more of the session to safety planning. When it comes to safety planning, my feeling is that using an app such as those available through the Black Dog, or documenting a safety plan. What are the means that you've thought about? How can we remove them? Who are the people that you can rely on in hours and after hours? Do you feel comfortable to speak to Lifeline? Would you accept the suicide callback line? When you're feeling distressed, would you use a PRN of medication? What PRN would be acceptable to you? Begins the process of building a plan and allows the person to understand that you're genuinely interested in their distress and their risk level, and begins the conversation about how we can work together to keep them safe. So that's the development of a collaborative safety plan in brief. I work to treat suicidal thoughts and behaviours, and there are many techniques to work through, and you have to tailor them to the individual, their capacity to abstract and what's acceptable to them. I often ask people how they think and feel about their suicidal thoughts, how distressed they are, how intense they are. And when a person describes that they feel as though they're struggling with the compunction to hurt themselves or to move along the process of a suicide plan, ask them what it is that would stop them from moving down that process, how we can alleviate their distress, and what suicidal ideation means to them. And try and demystify the concept of suicidal ideation and work with them around it being a signal for accessing support and help rather than a thought that forces a person to act on those thoughts. Another key issue is ensuring continuity of care. And when you're seeing somebody who is experiencing suicidal ideation, getting them in to see a psychologist or psychiatrist can be challenging. Being assured that the local community mental health team may not follow them up or may follow them up can be challenging at times. Ensuring that over the next week or fortnight that you've put in place a continuity of care plan, both in terms of their access after hours but in hours, to make sure that if they are experiencing distress that they can access you, but also that they're aware they can attend emergency departments to access care and support. There are an array of new government initiatives, and certainly in New South Wales there are funded systems approaches whereby government is funding different aspects of suicide prevention techniques within organisations to create a network or a mesh to catch people, to provide them with in-hours and after-hours support. And this is, I think, the first important step in terms of researching well what we can do to change the trajectory from suicidal ideation to completed suicide. We also know that the way the media portrays completed suicide and suicidal ideation and mental illness has changed since 1997, since the Mindframe Initiative, which was actually locally developed by what was called then the Hunter Institute of Mental Health, has now rolled out nationally and is changing the conversation around the acceptability of working with people with suicidal ideation and mental ill health, and the support that we should be providing to them and the care we should be providing to them. There's the National Suicide Prevention Strategy, which supports primary health networks to improve suicide prevention. There's Living is for Everyone, which is the kind of life resources, which is links and resources for suicide prevention for clinicians. There are an array of other toolboxes available through Beyond Blue and Black Dog Institute. But the key message here is that you're not alone, and that governments and individual clinicians are working together to better understand how we can mitigate the risk associated with suicidal ideation. In relation to our First Nations people, risk of completing suicide, and the rates are significantly higher among the Aboriginal and Torres Strait Islander population. Amongst that population accounts for 5.2% of all Indigenous deaths compared to 1.7% of all non-Indigenous deaths. Amongst Aboriginal communities, suicide was believed to be a very rare occurrence, but if we think about the impact of disenfranchisement, the stolen generation, the transmission of intergenerational trauma, the lack of access or fairly poor access to appropriate culturally sensitive support services for our First Nations people, one can understand that there is a lot of work to do in closing the gap between Aboriginal and non-Aboriginal suicide rates. And this is a national tragedy that continues to unfold before our eyes. So if somebody walks into your clinic and they identify as an Aboriginal or Torres Strait Islander, really reflecting on their trauma history and spending the time examining their social connectedness, substance use, the severity of their mental ill health, what community supports are available to them, and ensuring, if at all possible, we can keep them out of hospital where oftentimes re-traumatization can occur, but very carefully assessing the short-term suicide risk. We know that substance use rates are higher amongst First Nations people, and very carefully considering what local resources and culturally appropriate resources are available to support them in their journey towards either abstinence or substance use reduction. So Alex Lichtman writes a fair bit on why people complete suicide. He's got the 6 reasons that people commit suicide. So I thought I'd give you some punchy reasons, things to stick in your mind. People are depressed, by far the most common reason why people commit suicide. They are psychotic. That's a fairly rare event. But if you see somebody who's psychotic, they have no insight, and they're experiencing command auditory hallucinations to remove a chip from their gut, that's a high-risk person. When people are impulsive, that's often related to drugs and alcohol. Also think of the young person with ADHD or the middle-aged person with ADHD who's drinking more alcohol than usual. People tell you they're suicidal because they need help and they do not know how to manage their distress. And they're relying on you to be able to provide them with a framework which ameliorates their anxiety and gives them a sense of certainty in the short term. We see people with, for example, Huntington's disease, multiple sclerosis, cancer, who have a philosophical position that they don't want to live a life where their health and well-being deteriorates to a point where they're a burden to their family and they choose to no longer live. Oftentimes, people who complete suicide are young people who might be flirting with oxygen deprivation therapy, or they're flirting with the notion of suicide, or might have actually seen something on TV or thought that they would like to try to take themselves to the edge of death but not complete suicide, and unfortunately accidentally end their lives. And so just thinking a little bit about if somebody presents with their child and they're worried about their nitrous oxide use, and the child's been looking up different ways to die on the internet, but they're not actually suicidal. They just have an interest in exploring what these experiences might be like, talking through the risks with that young person, linking them in with a child and adolescent psychologist, talking to them a little bit about the impact for their family with these risky behaviours, looking at other ways they can express their desire for a rush of adrenaline, rather than experimenting with high risk, high morbidity and high mortality methods, is often helpful. I want to talk about the importance of following up after a failed suicide attempt. So a suicide attempt is the most significant risk factor for future suicidal behaviour. People who survive a suicide attempt may be resistant to engage in follow-up treatment. We have to work hard to ensure that they are. When people are lost to follow-up, these people are often people who miss out on appropriate care, support, treatment, psychotherapy, and the opportunity to recover. About 50% of people who attempt suicide do not attend any treatment post-discharge. So these are the gaps in the system that the federal government and state government are trying to close. But if somebody comes into your room and tells you that 3 weeks ago they took an overdose of medication, they weren't sure that they wanted to die, they didn't seek any further medical attention, they had a bit of a sleep and they're a bit distressed, take that seriously. Allocate more time to that person. Spend time developing a therapeutic contract. Work hard to understand why that person took that overdose. Don't accept the fact that, yes, they were trying just to get more sleep. Understand the distress they experienced. Try and link them in with a psychologist. Bring them back. Bring them back in 3 days. Bring them back in 5 days if need be. Avail them of resources that are available through, say, Black Dog and other local organisations, the suicide callback line. Assess their current level of risk. They might still be experiencing suicidal ideation, but they may have made a decision to not complete suicide because they're worried about the impacts on their family. But they are drinking alcohol or they're a regular pot user, and those factors then reduce their threshold for completing suicide. Take it seriously. People attempt suicide because of a high level of distress. Shifting from suicidal ideation to an attempt is a significant change in thinking and represents a significant change in their risk profile and should never be disregarded. 15 to 25% of people reattempt suicide, and 5 to 10% of people who've attempted suicide will die by suicide. For the 50% of people who follow up, 10% of those people will only follow up once. So you really actively have to reach out, use your practice nurse, refer them to a psychologist, use available resources, but track them, particularly in that immediate post-suicide attempt phase, which I'd consider the first 2 to 3 months. Get them back into your practice, connect with them, and then connect them with resources. Most importantly, the highest risk period for reattempt is within the first 3 months. If you can get them back into your practice and you can develop a safety plan, and you can then start to work through risk factors. For example, well, they don't have major depression, but yes, they are anxious. And my goodness, they had one panic attack which made them feel hopeless and moved them from suicidal ideation to feeling it was all too much. Let them know what you can do in terms of treatment of panic attacks. Let them know about deep breathing relaxation techniques and sequential muscle relaxation techniques, and get them linked in with a psychologist. Sometimes that might be challenging. Get them reconnected with friends and family. Allow them to have a conversation with friends and family about their distress and to be able to disclose to friends and family their suicidal ideation. Work with them around the shame and guilt they might be experiencing, because that's how you build a good quality safety plan. So now I'd like to talk about Peter. This is a case history. Through this case history, I'll demonstrate some of the risk factors to look for, some of the processes to think about. This is a de-identified patient. He's a 49-year-old male. He presents to the surgery and he's in a distressed state. He looks a bit disheveled. He's not shaven. His hair probably isn't as well groomed as usual. And he tells you that he left work today because he had an anxiety attack. Feels like he's not coping. He's really worried that he's at risk of losing his job. Finds that his attention and concentration and focus isn't as good as it usually is. He's worried about making mistakes and feels like he's behind in his workload. His background is that he's married with 2 adult children. He was previously a high-level athlete and he represented Australia as a rower. His current job is a financial advisor and he finds the job pretty stressful, particularly since there's been recent redundancies at work and he's been given some extra duties and he's feeling overwhelmed with that. He's got a background history of bilateral knee pain and he's got lower back pain, which limits his ability to exercise, which is one of his passions and one of his major stress relievers. His mum passed away about 5 months ago from cancer. He's very close with her. There's a previous history of trialing an antidepressant medication and he tried it for 3 months and he felt really well on it. So he stopped it and didn't seek medical advice. So I'd like you to take a minute and just think about what kind of questions you'd like to ask Eric and how you'd engage him and how you'd like to manage this process. My advice to you is to take a deep breath and take your time and go through and look at the metrics of depression. Assess his sleep pattern. Ask him about whether he's experienced initial insomnia, trouble getting off to sleep, middle insomnia, waking up through the night, whether he's waking up anxious with racing thoughts whether he's waking up in the morning with palpitations, he's anxious before he goes out to work. He reports an experience that he's really worried that he won't be able to support his family, and he feels more than a bit hopeless in that regard. Generally, he goes out and exercises, but now he's drinking red wine. He's finding he's stopping at the bottle shop on the way home. The alcohol allows him to get off to sleep, but reports this middle insomnia as well. There's a background history. His father had depression. There's an uncle, we think, who committed suicide. It's unclear. His wife is supportive. She's caring, and she actually suggested that he come in and see you today. He's got a really wonderful celebration coming up. His daughter is due to get married, but he's really worried about funding that. He admits that he's had thoughts which have been popping in his head. They've been brief, fleeting thoughts at first, but he's had thoughts of taking his own life. Perhaps when he's driving the car, he sees a pole and thinks, I could just drive into that. When you inquire a little bit further, he's actually spent some time looking up other methods of suicide. And when you ask him whether he's progressed those ideas, he says, look, I actually have a rope in my car. I went to Bunnings, I bought a rope, it's in my car. I haven't taken it out of the car, but I've got a shed. I was kind of thinking about, I was going to take it in the shed this weekend. I don't know where I'm at with that, but it's something that I'm seriously considering because I'm feeling stuck. So things that you should be thinking about, well, what's his previous history of suicide attempts or self-harm? What's his history of previous depression? So he's had the single episode. Does it meet criteria for major depression, or really was he just stressed? And why did he only take the medication for a brief period of time? What's his philosophical position on medication? Are there comorbidities? Is he experiencing panic attacks? Is he beginning to experience generalized anxiety symptomatology? What's his personality structure? Was there developmental trauma? So having his dad depressed, did he see that? Did that impact on him? Was he bullied at school? What was the quality of his relationships? How does he manage stress and distress? So looking at that, developmental history in terms of abuse. Did he experience an episode of depression in his teenage years or not? Did he witness domestic violence? And then what was his exposure to substance use in the house? What's his current attitude to his alcohol use? We know he's got this knee and back pain, and that's a significant issue. What do we need to do about that? Can we ameliorate that pain? Can we help him get a decent night's sleep? Is there a history of run-ins with the police or the law? Does he have a forensic history? It doesn't sound like it, but you need to clarify that. Things at home when he becomes distressed or frustrated. Does he become verbally abusive? Does he punch walls? Is there a history of that? So how does he actually manage distress and stress? His current personal risk factors are that he's presented with a mood disorder. It looks like he's involving major depressive disorder. There's the recent challenges at work. There's the alcohol use. You have to assess whether he's been using to the point that he could potentially withdraw from alcohol if you asked him to stop using altogether. How's he been managing his chronic pain? What's he using? What's he had in the past? What works for him? There's the financial difficulties. And then there's the possible restructure at work, which he fears will make it all come crashing down. What are his protective factors? His wife. Their relationship is a strong positive one. They've been together for an extended period of time. He feels that she understands him and supports him. He's also got an array of close non-parental friends that he's connected to. He also, whilst he's recently lost a parent, he's very connected to his remaining parent. Look at the rope, because that's an environmental risk factor. See what he thinks about getting rid of the rope and other potential means. See whether he'd be prepared to discuss with his wife that he had purchased this rope, that he did feel like driving into a pole, or does think about that when he's driving to work, and feel clinically what the tension is in terms of his level of concern about disclosing this to his wife and what his concerns would be, because having her involved in the safety planning process is going to be critical. In addition, has he used Lifeline? Would he feel comfortable picking up the phone and calling Lifeline or the suicide callback line, or the 1-800 mental health contact line, or ringing an emergency department or an ambulance? So just thinking those through, what would be the level of acceptability of those support services for him? So listen with empathy. Just take a non-judgmental approach. Oftentimes we want to solve the problems. Well, your financials, how much do you have on your mortgage? No, you're going to be okay. You could probably redraw on your mortgage. I wouldn't worry about that. Don't try and solve his problems with him. Understand his problems and work with him around what he thinks potential solutions might be to the situation. You might not have time to do that all today in that 15-minute session. So let him know that you understand his distress. Let him know that you are committed to working with him and helping him and supporting him through this difficult time. Look at what the immediate risk is. If you are comfortable that his wife is going to be with him, that they have a good quality relationship, that he would be prepared to talk to her about her suicidal ideation, and that you could get him back tomorrow for a longer appointment. And then you could work to develop a more detailed safety plan. But in the short term, perhaps you could document what he could do overnight, perhaps pick up the phone with his permission and speak to his wife and say, look, this is the plan that we've put in place. Are you comfortable with that? Do you have any concerns? Then you have that bit of corroborative history that would give you a bit of certainty overnight that he'll be okay. If you feel that PRN medication might be helpful to assist him with a few nights sleep, even though he is using alcohol, on balance, if you don't want to use benzodiazepines and you don't want to use second generation antipsychotics, then perhaps consider offering him melatonin drops. But first of all, discuss with him that alcohol is going to impact on his sleep-wake cycle. Create a framework that, yep, you're not sleeping at the moment. It's probably secondary to your depression, stress and distress. In fact, you're not exercising. So we'll need to look at those things as well. We need to get you sleeping tonight. Are you going to withdraw from alcohol? Have you ever had alcohol withdrawal symptoms? Okay, well, these are the options that are available to you tonight. We can try melatonin drops. If you don't like them, we'll find another solution for you tomorrow. If you're comfortable prescribing short-term temazepam or diazepam and have his wife monitor that medication and have that agreement in place, then you can try that. But making sure that it's short-term only. Having the wife agree, if you have his consent, to remove the rope from the car and dispose of it. If there are any other means that is thought of, perhaps he should take a few days off work and provide him with a medical certificate. So fundamentally, what we're doing is we're negotiating, first of all, a therapeutic alliance. Second of all, you're empathizing with his situation. Third of all, you're creating a short-term plan until you can see him tomorrow or the next day. Fourthly, you're harnessing local resources, the support of his wife, friends if need be, giving him time off work, ensuring that he's not drinking alcohol, which would reduce his threshold for acting on suicidal thoughts, and problem solving together with him. If you're very concerned, there are options such as, well, I could arrange a private admission for you, but it might take a couple of weeks. So how are we going to keep you safe at home? If you think the risk is untenable and that you believe that he's at imminent risk of using that rope, or that once he leaves your rooms, the therapeutic alliance that you've established with him doesn't leave you with a sense of certainty that he's going to be safe, then I would consider using the Mental Health Act. And I'd discuss that with him as an option. But certainly depriving a person of their autonomy is a serious undertaking. And so looking at understanding his depressive symptoms and perhaps discussing treatment pathways to reduce his anxiety and treat his depression might give him a sense of hope and might allow you to further your therapeutic alliance and then put in place a safety plan. Look for clues when people walk in the room. Never disregard deliberate self-harm, previous suicide attempts. Look for clues like somebody who's usually well presented looks a bit more disheveled, that they're sweating a bit more, that they've missed an appointment with you, and maybe the last time you saw them, they were a little bit worried because their relationship was unstable, or they mentioned to you that in passing that their job was a little bit unstable. Have those good governance processes in place in your practice to follow up with a phone call and see if they're okay and whether you can get them back into your practice. Sleep is pivotal. If you can ensure a decent night's sleep, whether it's using a benzo short-term or quetiapine or the dreaded olanzapine, which causes significant weight gain, or melatonin drops or slow-release melatonin, whatever it is you need to do to get a person sleeping so that the antidepressant or anti-anxiety agent can start to work if there is a diagnosable mental health condition present, that is critical. The relief that people experience with a single good quality night's sleep, I don't have to tell you about, because everyone sitting watching this would have seen the change that can occur in 24 hours. Remember that collaboration is key. Risk formulation that is dynamic, that is focused on working with a person with a good quality safety plan and good quality diagnosis around mental ill health, substance abuse, current psychosocial stresses, is your risk prediction process. And you can think about their baseline risk compared to the rest of the population. Well, they have depression, they're at high risk. That should be enough for you. We can't quantify at how much more of a risk unless the person says to you, Doc, I have a rope. After this, I'm going to leave and I'm pretty certain I'm going to end my life. That's when you enact the Mental Health Act. If there are no psychosocial supports for the person and you cannot engineer a reasonable plan for the person, unfortunately, that's when the Mental Health Act comes into play. Or if you have confidence in the community mental health team and they can provide an assertive outreach to that person and the person consents to it, that would be an appropriate use of that resource. Fundamentally, as a clinician, I've never been able to understand suicide and tragically, I have worked with people who have completed suicide, and I can tell you that at no time have I ever truly understood why it is that the people I've lost clinically committed suicide. And oftentimes, having to connect with families and support them provides no further enlightenment as to why that person chose to end their life at that point in time. Oftentimes, when I conduct psychological autopsies, review my notes, but also at a governance level where I sit as a director of quality and safety for an entire health district, looking at root cause analyses and trying to understand how systems have missed suicide risk or what we could have done differently. I have found very few cases where there's a clear clinical failure, but more broadly have seen systems-based issues, and oftentimes people with factors that I would consider in the lower sort of threshold of risk. Those sorts of people complete suicide, and people, perhaps because they're at high risk, receive more resources and more support. Oftentimes the people that I find that whilst I perhaps have a sleepless night or two about those people, in general my experience is that those aren't the people who complete suicide. So the GP's role really is to relieve the emotional pain that a person's experiencing. And that could be related to their broader psychosocial context, or in relation to mental ill health, or related to distress caused by substance use. So it's a really complex role that you have. And so asking you to connect with the person, help them understand that you're committed to their safety, their health and well-being, and that you will bring on board the network that is ever evolving and make those resources available to you. And when I say the network that's ever evolving, I'm talking about the local suicide prevention strategies that are being implemented in every local health district across our state and within each state, and then nationally, and just being abreast of those processes and what is available, and explaining to the suicidal person that those resources are all about helping them stay safe, and that they're not alone, and that you are prepared to see them the next day, and that you are prepared to go that extra mile if somebody's acutely suicidal will make a difference. But do not allow a person to walk out of your surgery without you feeling comfortable that your safety plan is acceptable to the patient, that has been developed collaboratively with the patient. And if you have a feeling in the pit of your stomach, give them a buzz at the end of the day to see how they're tracking. 5 minutes of your time might save their life.
Welcome to the GP Psychiatry Support Line webinar. My name is Dr Sally Lambert. I'm a psychiatrist at ProCare, and this is Dr Martin Cohen. He is a psychiatrist at ProCare as well. And we'll be talking about the assessment and management of suicidal ideation. So, Dr Cohen, what would you say is the professional role of a primary care provider in the prevention of suicide?
Mm-hmm. Well, as our colleagues watching this will be aware, that GPs are really the front line in terms of the volume of people that they'll be seeing. And we know statistically that 90% of people who complete suicide have a diagnosable mental illness, and that the vast majority of those people would have seen a GP within a few months of attempting or completing suicide. So it is an important role, and fundamentally they have a role both in providing screening, assessment and support. And that's particularly challenging nowadays because the volume of people coming through who are prepared to talk about their health and well-being in terms of diagnosable symptoms and signs such as depression or anxiety or PTSD and are prepared to disclose the fact that they might be experiencing suicidal ideation is increasing. And so I have a great deal of respect for our colleagues, but that is their primary role currently. Yeah.
So what would your advice be for GPs in terms of the process of assessing suicidal ideation?
GPs have to really work with people across all ages. And so there needs to be an age-appropriate assessment process. Now, certainly I'm aware of certain practices that prefer to work with people who have mental health problems, and within each practice there might be people who identify with a particular interest. So I think just understanding who's within your practice and what kind of management processes you have if a new person turns up for a one-off assessment or for a short appointment and they're presenting with suicidal ideation, or on one of your screeners you're concerned about their level of risk. So that's the first thing. I think the second thing is having recurrent in-services in relation to who's doing what services are around, who's having success in relation to accessing psychologists. Those sorts of things can lead to an increased level of comfort when somebody comes into your room and they might present with, say, non-specific gastrointestinal symptoms, and then you elicit a history that perhaps they're experiencing trouble sleeping, they're having challenges at work, and so slowly the history's evolving and you're understanding that perhaps there's either mental ill health or mental illness. And so being non-judgmental, being open to hearing a person's description of their challenges is really important. I think we often would like to move into and assess symptoms really quickly, but I find that we just cover a lot more ground if you let a person talk for a couple of minutes and ask them how they've been tracking, what challenges they've been having. If there's anything unusual in terms of their experience recently that they wanted to discuss with you. If you suspect somebody is presenting with suicidal ideation and you feel like you've gone through a whole series of physical examinations and at the end of the interview you just don't feel like you have enough to say to a patient, well, can you tell me about whether or not you feel as though your life isn't worth living anymore? Ask them, is there anything else that I haven't asked you that's important for me to know? Do you worry about your safety? What kind of supports do you have around you? And depending on your level of engagement with the person and depending on their linguistic structure and how you comprehend that they put together their understanding of their challenges, the skill is really in leveling your questioning, and they should be open-ended questions, at the right level for that person. And I guess that's the challenging bit.
And if they do say something scary or that worries you, it's sometimes hard to know how to respond to the patient, in the room. Would you have any advice about that?
Yeah. Well, I guess, again, depending on the person's sort of interpersonal style and what you pick up, but oftentimes just expressing empathy, just saying and reflecting back to the person what you've heard. My goodness, so you've been thinking about suicide for the past couple of weeks. Tell me a little bit more about that. And you can open up that way. Whereas if somebody's perhaps very closed and they mention in passing that they've had suicidal thoughts but they don't want to talk about it, then you perhaps can move into more systematic questioning and saying, look, I'm a bit worried about what you've said. Do you have any anxiety about me asking you some questions about your safety? Because part of my role is to ensure that when you leave here that we've got a reasonable plan in place in terms of what's happening for you, but also I would like to ensure that you are safe and that if you need to speak to somebody after hours, that we've got some resources in place for you.
So for people who might not be so confident at assessing people who present with mental health problems or suicidal ideation, is there a role for screening tools, and would you recommend one?
Horses for courses here. I think something like the PHQ-9, which is very straightforward. I think it's a 9-point questionnaire that does address suicidal ideation, but also depressive symptoms and anxiety symptoms and sleep-wake cycle, I think is very helpful. And particularly if you're feeling uncomfortable in relation to your experience in working with people with mental health problems, it might be something that you collaboratively do with the patient rather than having them complete it out in the waiting room. Yeah. Now, the sensitivity and specificity of these questionnaires is okay, not great, but it's really about the conjoint process, the collaboration around exploring those questions and asking about symptoms and asking about intensity of thought, frequency of thought, planning, searching the internet for means. So it provides a conduit to explore those questions. There are many other questionnaires available that explore suicidal ideation in much more detail. Quite frankly, I don't use them clinically. I'm guided by the patient and I'm guided by what my specific purpose in that assessment is, which is to make sure that when that person leaves a room, I have a safety plan and I've got a good grasp of their risk profile.
Yeah. A patient identifies that they're having some thoughts about suicide. What would you say would be your process at management of this patient from this point in time?
Well, I guess I want to understand, first of all, what their mental health status is. You know, am I seeing somebody who has complex trauma, they've experienced suicidal ideation from an early age? That doesn't lower my risk threshold.
No.
But it gives me context for understanding whether the current suicidal ideation is more intense than their baseline, whether there's supervening anxiety, depression, substance use, an eating disorder, previous suicide attempts, of course, and deliberate self-harm. So I'll look at all of those metrics and I'll put together a formulation as to what my risk metrics are before I move forward in terms of a safety plan. I'll also ask them whether they've seen a psychologist or an OT and whether they've had a safety plan put in place before and what their experience of that was. Because if it was very formulaic, oftentimes I find that people will be quite resistant to putting together a safety plan.
Yeah.
Whereas for some people who perhaps have experienced complex trauma and they've lived with suicidal ideation for much of their life, really what they want is for me to understand that it's a symptom of distress and that we need to put together a plan that addresses their distress and their presenting complaint before I'll be satisfied that we have a comprehensive safety plan. For other people, it's really about making sure they're connected to friends and family members, that if they're feeling distress, that we know who they'll call. If they have thought of means of suicide, that we remove those if possible. And if we can engage a family member or a friend to remove those means, so if there's a noose or if they're thinking about overdose of medication, that we get a Webster pack in place, so that if at all possible, we make sure that the environment is safe and that we've got in-hours and after-hours connection to services. And whether that's a clinician or a counsellor, or whether it's my rooms or the general practitioner, or whether it's a suicide callback line, whatever service is acceptable to that person. Some people don't like speaking to strangers and telling them about their suicidal ideation, and so giving them a formulaic sort of list of numbers doesn't work for them. Yeah. So just checking in that the reason that they presented today has actually been addressed. And whether that's a plan in relation to treatment of depression, or if you're not certain, referring them on to the right person and getting a structure in place so there's a sense of surety around if they need to see a psychiatrist or engage with a psychologist, whether they have panic attacks, developing an understanding of what panic attacks are, because they're scary and sometimes people think they're dying so they might, they think that it's easier to end their life because, suffering through panic attacks is awful. And so addressing their specific concern and then developing a plan that addresses immediate safety, connection with supports, access to services in hours and after hours, and then setting up a review time, and then treating as appropriate sleep disturbance, substance use issues, and making sure that wherever possible access to means are removed.
Okay, so what are some risk factors that kind of worry you?
Okay, well, obviously a past history of suicide attempts, and I'll often ask the person about their emotional response to that suicide attempt, and I'll try to understand the context of how it occurred. So were they intoxicated? Were they isolated? Did they intend to actually die? Did they write suicide notes? Did they spend time wrapping up their affairs? So that the actual risk profile associated with each attempt is important to understand. It's sometimes challenging within a short appointment to be able to do that, but you do the best that you can. And I think a person's connection to a future, a person's, so if they're experiencing suicidal ideation, they have a history of past attempts, understanding where they are in their risk profile, and people will understand that. And oftentimes they'll be able to help you understand what their metrics are moving from suicidal ideation to acting on suicidal thoughts. And there's a lot in the literature about the difference between suicidal ideation and then moving to intention. And there's a whole range of neurobiological hypotheses about changes in neural networks, which we won't go into today, but actually intervening at that level and helping a person understand that suicidal ideation is a symptom of distress rather than a thought to be acted upon. And so sometimes simple cognitive behavioural strategies to help them manage those thoughts, and if need be, PRN medications will be helpful.
Yep.
History of deliberate self-harm, eating disorder, depression. Of course, if somebody's psychotic, experiencing auditory hallucinations commanding them to end their life, that's of concern, but that's a rare presentation, really.
Yep.
Then level of social connectedness, financial stresses, substance use, and then disorders that impact on impulse control, ADHD, again, substance use disorders, those sorts of things, brain injury, and then comorbid physical illnesses. Somebody's presenting with a new cancer diagnosis, background history of multiple sclerosis, those sorts of things, they are significant factors for completed suicide. And so helping a person understand that the gravitas of their physical diagnosis and how it impacts on their sense of hope and their sense of future at least starts to build a bridge between yourself and their suicidality. There are a range of other risk factors, but I think in a nutshell, that's all we need to really remember. Yeah.
Yep. So at the moment, we're in the middle of a pandemic. I just wonder if that has an impact on how GPs might assess or manage people with suicidal ideation.
Yeah. Look, I think we're seeing an increased demand for services. So if you look at presentations to emergency departments with deliberate self-harm, suicidal ideation, that's increased significantly. Certainly in the media, and our academic colleagues are foreshadowing an increase in demand. To respond to that, I think government has increased the number of psychology services available to, I think, 20. And in addition, there have been, specifically in New South Wales, but also across Australia, funding of specific suicide prevention programs. Now in New South Wales, we have a systematic approach. It's called a systematic approach. Essentially, it's looking at a range of moderately evidence-based approaches to assessment and management of suicidality. But the process is to increase the number of services and link those services together to reduce the number of people falling through the gaps. Now, in the context of COVID, if we think a little bit about the impact of chronic stress on the hypothalamic pituitary axis, and you think a little bit about the neurobiology of suicide, which is a very complex area, to be frank, if you think about the studies, what we know is that chronic stress, putatively methylation of one of the glucocorticoid receptors is implicated in increased risk of suicide. We also know that people who are suicide completers have larger adrenal glands. So if you think about those sorts of things, and we think about the amount of stress that we've been through over the past 12 months and moving forward, the level of uncertainty, this isn't a political statement, but JobKeeper being pulled back and people wondering about their finances, an economy that is kind of stalled, maybe improving a bit, but also a lot of uncertainty in terms of our future. And then a raft of people who have not accessed services that otherwise would have in the past 12 months, who are now starting to access services, both with chronic health conditions such as rheumatoid arthritis, diabetes, and starting to re-access services and have been socially isolated. All of those factors suggest that we're moving into a high-risk environment.
So you talked before about making sure the workplace was skilled and having sort of regular in-services about resources available. And in my experience, it changed. It's a bit of a evolving field. So could you tell me about the latest resources that are available to primary care providers at the moment?
Well, first of all, I don't want to supplant the roles of the primary health networks and what the work that they're doing, because they're constantly funding and developing models in line with each state's suicide prevention plan. But services like the Suicide Callback Line are amazing. The Wayback service, there are a range of services like that that are designed to pick up and work with people after they've either had a suicide attempt or self-harm attempt. Mm-hmm. The challenge is that because these services are upscaling differentially across the country, it's really about local knowledge and actually relying on what is being fed out from the PHN in terms of which services are available, which ones are upscaling, which ones have availability. But also in each state, I believe that health pathways, mm-hmm. which is, it came out of, I think it was the Canterbury earthquake, it was in Canterbury, that actually saw the development of a series of health pathways for each different health conditions, so diabetes, suicidality, and I think you'll find that your local health service has a pathway that reflects both what public resources are available, but also has really handy things like a suicide assessment protocol, a safety plan, and then available resources that are local and connected with the public health service. Word of mouth is also very important, and speaking to your colleagues and finding out what they've had success with lately is very important. And then I think lastly, if you actually have a look at your local mental health commission's website, you'll find out about additional resources, both in terms of the First Nations people and the current strategic plan for upscaling of services, but then also what the strategy is for your local area. And there'll be regular meetings whereby the Commission will be meeting with consumers, carers, and providing advice back through their website as to what they identify as the need is, and then feeding that back through their government arm in terms of service commissioning. So all of those resources are available. There's no list that I can give you, but just building your own list and every month just refreshing it. Because it's very difficult to get somebody to see a psychiatrist because our workforce hasn't developed to meet the demand.
No.
And so, for example, the GP Psychiatry Support Line is a really valuable resource because it allows people to access a skilled clinician like yourself and like myself to get advice. And in tricky situations, it allows you to implement pharmacotherapy and put in place a plan with the consultant's advice, and that makes a difference. It helps people sleep at night.
Yeah, I was just about to say that. It's nice it would be nice to run the plan by someone who is an expert. I guess these are pretty emotionally charged situations for a GP. It's scary, it can be sad, it could be traumatizing hearing about some horrible things that a person might have experienced. How would you say someone could go about attending to their self-care or checking in to make sure things are going okay for them?
Yeah, I think that's a really important question because we as doctors are not immune to the impacts of COVID and normal day-to-day stresses and the demands of seeing 15, 20 people a day. And certainly in my own practice, I've noticed that the number of clinicians that have been referred to me is disproportionate to any other year that I've seen. I guess looking out for your colleagues is important, but also recognising that some people are more open to talking about what's happening in their personal life at work and a bit more chatty about it, but looking at whether your colleagues are coming in a bit more dishevelled or cancelling clinics or but just in general, just getting a feel if they're less bubbly, if they're seeming tired, just checking in that they're okay. I think it's worthwhile if you're a practice leader, having your practice manager just be tuned in and touching base with your clinicians on a regular basis, and also looking at workload, the amount of time people are spending back to complete notes, those sorts of things. Because if information processing is slower and a person's stressed and they're not sleeping well, they'll be working till 7, 8 at night. If they seem a bit more anxious and they're constantly asking for advice, whereas that's unusual, just checking in and making sure they're okay. We need to take holidays as well.
Yeah.
One of the things that is difficult to accept, but we're all replaceable. And fundamentally looking after our own health allows us to make change at scale. And so, prioritising and ensuring that there's time for family and holidays. Thinking about your own patterns of behaviour, and if they are moving to perhaps a significant change that you recognise is not usual for yourself, then looking for supervision,
Yeah.
talking to a trusted colleague, and if need be, taking some time off.
Yeah, that's great. Well, thank you very much.
Thank you for asking me to be here.